Thank you all for coming to this Goodman Institute event. It's nice to have you all here, especially to discuss an issue that is seems to be on everybody's desks right now. And for an issue that we all talk about so often, there's really not that many experts that we look to fill in our knowledge and our understanding of what is going to happen and what should happen. And we're privileged to have two of them here today. Mark McClellan ran Medicare and Medicaid for a few years. He's now at Brookings and has appointments at Duke and Texas. Dr. Goodman, sometimes referred to as the father of health savings accounts, now is president and CEO of the Goodman Institute, and it's my privilege to bring Dr. Goodman up to the podium to kind of set the stage for today's informal talk.
Well, all of you know there's a Cadillac tax in Obamacare. You may not know that just about every Republican proposal that's been put forward has its own version of a Cadillac tax. The Republican versions tend to be kinder and gentler, but the idea is still the same. And I'm going to give you an example, a numerical example that I'm going to walk through, and I'm just going to use numbers that are easy to deal with so you don't have to get out of a pocket calculator to figure out what's going on here. So in my example, I'm going to assume that we're going to tax insurance plans that cost more than $20,000 for family coverage. Okay? And in the Obama care, it's $27,000. But I'm picking a nice round number so we all see how this works. And it works the same way for the Republican plans. Let's go to the current system. In all the examples I'm going to give you, I assume that the employer has $20,000 at the margin to give to his employees. And the reason he's giving this $20,000 to employees is because he has to do it so that his total compensation plan is competitive with all the other employers and equals what employees could get elsewhere. And so the only question is, how much of this $20,000 is this employer going to spend on wages, and how much is he going to spend on health insurance? And economics tells us that he's going to want to do it in a way that most pleases the employees because he wants to keep his employees and he doesn't want them to go somewhere else. So it's really the employee preferences that's going to govern the decisions that the employer makes. Now here's how the current system works. If the employer gives this $20,000 to his employee in the form of wages, it gets taxed. And in this example, I'm using an individual in the 40% marginal tax bracket. Now 40% means higher income, but just to put this in perspective, most members of Congress are in the 40% tax bracket, okay? And also 40% is the tax in Obamacare, and it just makes it easier to walk through this. So we give the $20,000 to the worker in the form of wages. At the 40% tax rate, the government takes $8,000 away, and the employee gets to go home with $12,000. Okay. Alternatively, if this employer spends this $20,000 on health insurance, as I think all of you know right now, it is all pre-tax, it is not taxed, it avoids payroll taxes, avoids income taxes, so the full $20,000 gets to be spent on health insurance. Now, economists don't like this. And it's economists across the spectrum, from right to left. I mean, Jason Furman doesn't like it any better than I like it. And all economists think this needs to be changed, and the people who put Obamacare legislation together thought it needed to be changed. Why? Because what you just saw encourages overspending on health and overspending on health insurance. You know, if wages are taxed and health insurance isn't, that encourages us all to overconsume health care. And in this particular example, $1 of health care is going to trade against 60 cents of other goods and services. And that means that the health insurance needs only to be worth 61 cents to be preferable to paying taxable wages, all right? So basically at the margin, people are buying health insurance, they're spending $1 on health insurance, it really isn't worth $1 to them. And they're doing it because otherwise they would have taxable income. Bottom line is people can always, under the current system, lower their taxes by asking their employers to spend more on health insurance and less on wages. So this is what economists call a perverse incentive. It encourages people to do things they wouldn't do if we didn't have this perverse incentive in place. Now let's let's create our Cadillac tax. We're going to say that if the insurance costs more than $20,000, we're going to tax it. In this example, we're going to tax it at the 40% rate. All right, so our employer does that. He has $1 more thousand to spend, and if he gives it to the employee in wages, what happens? Well, he gets taxed, he loses $400, and he gets to take home $600. But on the other hand, if he spends that last $1,000 on health insurance, now, because of our Cadillac tax, we're going to apply the 40% tax to this extra $1,000. I don't know why we couldn't get the numbers in a row, but the result is that only $600 is left to buy the health insurance. Now in this example, we put everything on a level playing field. At least for this last $1,000, we're not encouraging health insurance or wages. It's all on a level playing field. Now, I'm going to tell you that under Obamacare, it's not quite a level playing field, because at least in the Obamacare legislation, that $400 Cadillac tax is not deductible for the employer. And if the employer can't deduct that tax, it means that really it favors wages more than health insurance, because he can deduct wages. And also, something that's not talked about very much, in deciding how much this employer has actually spent on this employee, they're going to add in any health savings accounts deposits and any contributions to a flexible spending account. Now, last time I looked, federal employees didn't get flexible spending accounts. Is that still the case? You all don't have one. You know? Oh, you do have one. All right, so you know what it is. All right, well, any contribution you made to a flexible spending account, even though it had nothing really to do with your employer's health plan, that gets counted in the $21,000. So really, the Obamacare Cadillac tax, once you get above the threshold, it really favors wages over health insurance. The Republican plans haven't been that specific, but I gather from what I can tell, listening to them talk, that they would like a level playing field for their Cadillac tax, and that's what you see right here. What's wrong with the Cadillac tax? Well, in the first place, it has no effect on any plan that costs less than $20,000. So if the employee and employer have a $19,000 family plan, it doesn't affect any decisions they make, right? And secondly, for those plans that do cost more than $20,000, as the one in my example, it doesn't have any effect on the first $20,000. It's only that last $1,000 where we cause people to stop and think, well, do we really want it to be spent on health insurance, or would we be better off taking this and take-home pay? Now I want to show you what I think is a better approach. And not only do I think this is a better approach, Jason Furman wrote a whole paper explaining why this approach is better. And it's what we call the tax credit approach. And the way that works is we'll go back to the $20,000 insurance plan that we started with. And what we do now is there's no Cadillac tax now. And there's no, instead of doing that, we're going to give people a tax credit for health insurance. And the way this works in this example is we're going to give them $1 credit for $1 of spending up to $8,000. Any problem with that? So that in this example, the government subsidy for this insurance plan is exactly the same as it is under the current system, $8,000. The number has not changed. But the difference is, with the tax credit, the money goes up front. The money goes for the first $8,000 that we spent, and the last $12,000 is all on the same level with wages. The last $12,000 is not subsidized at all. All right, so what we're doing here is we're targeting our subsidy toward the core insurance, the first dollars, the insurance coverage that we want everybody to have. And what they got for that $20,000, well, that may not be worth very much to employees, but we're not going to subsidize it at all. So once we've done this, the last $12,000 in spending on health insurance is exactly the same as wages. If the employer and the employee find a way to cut back on waste in health care, let's say they cut it in half and manage to save $6,000 on their health insurance, that can be $6,000 of take-home pay. That's why economists like this. We've put the last $12,000 on a level playing field with wages. We've pushed our subsidy up front, so we're subsidizing only the core insurance. And for the last $12,000, any efficiencies anybody finds he can take home, or in principle, the employees and the employer can agree to pay it as take-home pay. All right? Now, what kind of efficiencies am I talking about? Well, in the Dallas-Fort Worth area, there must be, I don't know, 35 or 40 hospitals. And last time I talked to them, Blue Cross of Texas said there's not a single hospital in Dallas and Fort Worth that's not in their regular health insurance plan that they offer to employers. Not one is excluded. It doesn't matter how good they are or how bad or how expensive or how inexpensive, they're all in the network. So what the employers and employees might do is say, look, if we restrict our network to 2 or 3 really good hospitals that have high quality but low cost care, we can save a bunch of money. In fact, they might save $6,000. So when I say there could be a $6,000 savings here, this is not pie in the sky. You really can do that sort of thing, but you've got to restrict choices. You've got to have to give up something. But here we have everything on a level playing field. So employees can ask themselves, well, how much is it worth to us to be able to go to every hospital? Is it worth $6,000? And if it's not, then they can have it as take-home pay. So the current system is wasteful. Our new system, we have done what economists like to do, and that's give everybody good incentives. Our entire subsidy is directed toward the initial spending on health insurance, covering core insurance that we want people to have. Beyond that, every dollar of savings can become a dollar of take-home pay. All right, so people are rewarded by a dollar if they save a dollar. Whereas on the current system, in this example, if they save a dollar, they only get 60 cents. People cannot, under the tax credit approach, lower their taxes by buying more health insurance. Doesn't matter how much health insurance they buy, they still only get $8,000 of credit. So we've removed all the bad incentives. We've got just as much encouragement to buy health insurance as we started with, but we do it in a way that gives everybody good incentives, not to waste dollars on health care, but to only consume health care to the extent that when they spend a dollar, they get a dollar's worth of value. Now, with that, I'm going to turn the floor over to Mark McClellan, who knows more about this than I do.
No, it's not true. But I wanted to thank not only you all for coming, but the Goodman Institute for putting this on. It's been great working with John over the years. He's a no-nonsense kind of guy who likes to cut through a lot of the rhetoric and really focus on applying analytic principles, especially economic principles, in healthcare. That's not always easy to do. It can get confusing and complicated, but it's a really valuable perspective to bring. So I just like to make a few comments that reinforce and add to some of the comments that John made. First of all, this is a very timely discussion. Do you all know what's in the budget agreement on this point yet? I haven't seen the final word, but talk about timely. I've got a great timing there, John. This is a very important issue where, you know, this is a time when there's a lot of partisanship around many issues in health policy, but this is not one of them from the standpoint of economists and many health policy experts. There's kind of bipartisan concern about the very costly support for generous health insurance plans, generous third-party health insurance plans that's built into current law. And John just went through the math with you on that. I just like to highlight the practical budgetary and policy consequences of it. People talk about loopholes in the tax code and how there may be an opportunity coming for bipartisan support for tax reform that does things like close the loopholes and lower the rates and provide some better incentives as a result. Well, the exclusion for counting employee health insurance is not just a loophole, it's really the chasm in the tax code. This has a federal value now estimated in terms of foregone federal taxes at over $300 billion. There are implications for state taxes, for payroll taxes as well. All of that could be used for other purposes, lowering the overall tax rates and providing some of the benefits for improved access to efficient health insurance that John was just talking about. So the provision in the Affordable Care Act, the Cadillac tax, isn't what many Republicans have exactly advocated, but it would have those similar kinds of effects on limiting the incentives for healthcare spending, especially third-party spending, would also lead to some revenues. And an indication of bipartisanship is that similar proposals really are at the heart, as John mentioned, really are at the heart of just about every Republican replacement proposal for the Affordable Care Act. Now, there are some differences between the Cadillac tax and what's in many of these Republican proposals. As John pointed out, the Cadillac tax is an excise tax on health insurance plans that are associated with total employee spending above a certain level of expenditures, and that includes spending on the health insurance, spending on the HSA, spending on the flexible spending account. But the intent and the people who supported the law was to have an effect similar to what a cap on that tax exclusion or a limiting of that loophole would be. This, I guess, nominally avoids calling it a tax on employee benefits, since it's a tax on health insurance plans, but John went through the basic economics of how this works, and the reason that this is getting such attention now and is potentially part of the budget agreement is that a lot of employers have pointed out that this is causing them to change their behavior, to change the way that they're designing benefits, to think about shifting more of their employee compensation into wages or into other support for employees to meet their out-of-pocket costs. So it is having a significant effect based on the fact that this is getting so much attention in legislative, the delay in the Cadillac tax is getting so much attention in legislation right now. There are some problems with it compared to doing a straight cap on the tax exclusion, as John described. One is that it does, I think, add to some administrative complexity. In many cases, employees get their health insurance and health care support from more than one source, not just a health insurance plan, but maybe an FSA or an HSA, maybe different types of benefits. So in order to administer this, you've got to add all of that up at the individual level, and then the tax is levied somehow across those different contributors to the employee's health care support. And as you know, the IRS has asked about guidance on how we can administer all this. It's kind of complicated as opposed to just a direct limit on the tax exclusion that any individual can take, which is pretty straightforward to apply at the individual level. It also has a different incidence, to use an economist word. It's a different impact on people at lower versus higher wage levels compared to a tax exclusion. A lot of the Democrats and others who have supported tax credits point out that those are worth the same regardless of how much taxes you owe, that a tax deduction for health insurance isn't worth much to people who don't have a very high tax rate. Conversely, a limit on the tax exclusion doesn't cost much to people who have very low tax rates, whereas this 40% excise tax, that's an equal whack regardless of your own personal income category. So that's going to have a bigger impact on potentially affecting the benefits and the value of health insurance support for lower income workers than something equivalent accomplished through a tax exclusion would. So the tax exclusion proposals that Republicans have generally supported gets around those kinds of limitations, and maybe that suggests there is a bipartisan path towards addressing some of the concerns while still creating these useful both incentives for avoiding unnecessary health care costs and for redirecting these funds in a better direction. I do want to note some sympathy for the large employers that are having challenges with rising healthcare costs or concerned about the well-being of their employees. And the same thing for other Americans who might be affected. That's why it's so important to couple proposals to limit the tax exclusion, to redirecting some of those funds to have a bigger and better impact on access to care and on creating a higher value healthcare system. John worked through in his examples how some of the Republican proposals and also to some extent the refundable upfront tax credits in the ACA can help accomplish that goal. There are different ways exactly to get there, but again, the reason that there's bipartisan support among many policy experts for these types of reforms is because they do get more bang for the buck in terms of impact, high-value health care for people who are having trouble affording it now. I think there are also some further reforms that could be coupled with steps towards implementing the cap on the exclusion or some version of the Cadillac's tax effectively. John highlighted how just shifting this kind of system to one that encourages people to pay more attention to their healthcare costs can lead to changes in behavior and more value for the money. There have been a number of studies that supporters of keeping this tax exclusion in place have pointed to, suggesting that when people cut back on their costs, well, they don't necessarily cut back on just the low value care, but there are a lot of ways to work around that. HSAs is one. Some of the steps that are taking place in private health plans around reforming how they pay for health care to encourage the providers to work with consumers on getting more high-value services for a lower cost, which these reforms do encourage. That's another. One that I'd like to see a lot more of is extending out the consumer engagement in these kinds of reforms. So we've talked about for somebody who's maybe relatively healthy, how having an HSA and having being subject to a limit on their tax subsidy for health insurance could encourage them to maybe think more carefully about things like elective services and some of their early out-of-pocket costs. What I'd like to see is models that do much more for people with more serious chronic diseases. Actually, those individuals who have learned to live and their family members who have learned to live with costly chronic illnesses are probably some of our most knowledgeable consumers. I mean, they know what works for them, they know what doesn't, they're familiar with some of the challenges related to their particular illness. John's had some proposals in the past that would do much more to let those individuals have control over all of the dollars that are being spent on their behalf, not just the HSA money that might be used up front. But if you think about a benefit where if someone chooses a less costly system of care for their diabetes or their cancer, one that can get them better results, they could actually share in the savings more. That would really drive some changes in care. Many of you know me or may remember me from the time when I was at CMS and we implemented Medicare Part D, and one of the key features of that approach was this idea of just giving seniors a set amount of money towards the cost of their drug coverage. And what most of them did with that money was choose plans that had a kind of tiered benefit design, where if you switch from a brand to a generic drug in a traditional insurance plan, you might save 10-20% of the cost. But in the plans that people chose, all of that savings went to them. So you could switch from a brand to a generic in one of the popular Part D plans, you save $90 a month. So that full savings is shared with the consumer. I want to contrast that with some of the shared savings approaches that you may have heard about for healthcare providers, things like accountable care organizations and bundled payments. Those are all good steps. But if you really want to have a powerful impact on changing care, do what happened in Part D and get the consumers an opportunity to share in more of those savings, especially when they have high costs and high needs. Critical to making that work is giving people very good information on the quality and cost of their care. Maybe that was somewhat easier for us with Part D because people do seem to view appropriately brand name drugs and generic drugs as equivalent. It may be harder to come up with good evidence on whether one particular system of care for cancer or diabetes is as good as another, or one provider is as good as another. But we're making progress on that, and these reforms would definitely help us get there. So instead of going back and slowing down on what could be a really good opportunity to engage consumers more in spending dollars on their behalf wisely in healthcare, and there are trillions of dollars at stake, this could be actually a bipartisan opportunity for looking at how you can make proposals like the Cadillac tax or the similar Republican proposals work more effectively to help empower consumers and get costs down while actually improving the quality of care. So thank you all for the opportunity to join you today, and John, I'll turn this back over to you.
I just want to make one more point, and then we'll open it up for questions. I want you to consider a really lavish plan, administered, say, by a labor union or by an employer. Let's say it's a plan that costs $30,000 for a family. Now, if that plan were taxed like wages, the tax would be $12,000. The fact that it can be purchased with pre-tax dollars means there's a $12,000 tax subsidy there, encouraging that plan. So along comes John Goodman and he says, I want to give you an $8,000 tax credit. And the employer says, oh my gosh, we're getting 12 now, you want to take $4,000 away from us? And the answer is yes, I do, but they are not necessarily worse off, because I want to give them their $8,000 again up front and give them the opportunity for the next $22,000 to find savings, and any savings they find can become take-home pay. Now, in my opinion, if you're spending $30,000 on a family and you can't cut out $6,000 of waste, you're not trying very hard. But if they did find $6,000 of waste, then they get $6,000 of take-home pay, so they lose the $4,000 of taxes. They get $6,000 to take home, they're better off. Now, a year ago, I spent a whole day at the AFL-CIO building, and they haven't put my picture up on the wall yet, but they didn't kick me out the door either. And I've spent a lot of time with Business Roundtable, and same thing there. And I find that when you explain this to big business and big labor, and they put a pencil to it, it all begins to make sense. So a lot of people around here think it's will never change the employer system, and most Republican plans don't change it, and Obamacare didn't change it very much, except for the Cadillac tax. I think we need to think more radically. I think we need to think about going to a much better system, and I'd like to see a Paul Ryan proposal to do that. I think we're going to get it. But yes, I think once the special interests put a pencil to their own interests, they'll find that, yeah, this is a real opportunity for them. Okay, we'll open it for questions.
Kevin Ashley from Congressman Hastings' office. In order to implement this as a tax credit, wouldn't it really mean that that money which is spent on health care by the employer becomes wages?
Here's the way it's going to work in a bill I'm working on with Pete Sessions, and here's the way it works in Senator Cassidy's bill, who I also worked with. On April 15th, okay, we're going to give individuals in the Sessions bill $2,500 tax credit, $8,000 for a family of four. So let's just use the $8,000. We're going to take all the tax-free benefits you got from one employer, or as Mark said, it might be several employers. That's all going to be reported on your W-2 form. We're going to take that money and calculate what kind of implicit tax break you got. And if it's less than $8,000, we're going to give you more. But if it's more than $8,000, we're going to claw you back. So what you said is true, but we're going to do it in a way so that people can't say, hey, you're taxing our benefits. No. We're giving everybody a tax break, but we're not going to allow them to double dip.
That is the sort of the full-on movement away from relying on this tax exclusion, instead giving people some very clear, understandable, predictable support for their health care costs. It's much less tied to their income than the tax exclusion is today. There are some Republican proposals that are sort of a big step in that direction, but don't go all the way to, as we call it, equalization of employer versus non-employer coverage. For example, Senator Burr and Senator Grassley's bill this past year would limit the tax exclusion for employer coverage, but continue a good bit of it, just limit it. And as an alternative for people who don't get coverage coverage through their job, they'd get a credit towards the purchase of their own health insurance, and you know, it provides more equalization than we have today, but doesn't, you know, completely or fundamentally disrupt the employer coverage system. Some of the presidential candidates like Jeb Bush have proposed something along those same lines. So it's a big step in this direction. It doesn't go quite so far as what John proposed, though, but I think still very important improvement over the status quo.
Let me just say one more thing, and then we'll take your question. I think if you're going to have health reform, somebody needs to stand up and say, here's why we're doing it. Here are the principles we want to follow. And it seems to me like one very good principle is we're going to treat everybody the same. We're not going to have this guy over here getting $10,000 of benefit and this guy getting $2,000, and they make the same income. So let's treat everybody the same. That's tax fairness. And the other thing is, let's make it clear what this tax subsidy is all about. In the Sessions bill, we've got it at the Medicaid level. You know, the CBO tells us it takes $2,500 to put an adult in Medicaid. It takes $8,000 to put a family of 4 in Medicaid. So the numbers I've been using with you are what Medicaid costs. So the tax credit, I think we ought to have, it would allow you to buy Medicaid-like coverage. Anything more than that, you pay with after-tax dollars. But we put a floor under what everybody can have. And I think if we did that and we talk about it that way, at least some people can understand it.
I just had a quick question. It kind of follows up on that because you said become wages, and you kind of alluded to this earlier, although you used the word in principle, the words in principle, because you said that, you know, okay, so we give you this $8,000 credit, there's a $4,000 difference, and you said that can become wages. And I think what I'm trying to understand is you didn't say does become wages. And so I wonder if you can just be a little bit more clear about where that money goes, and if it is the case of the employer who says, oh great, awesome, like that doesn't necessarily mean that those are going back to the employee.
The labor union and the employer got an agreement on their health insurance. All of a sudden we changed the tax law. Now we haven't changed their agreement. We've just changed the financial incentives. So when I say it's potentially take-home pay, I mean they have to sit down at the table and agree to a change. But we've given them strong financial incentives to do that. That's what I mean.
Yeah, and I know there are always, people always like to point out the differences between economic theory and reality, but this is one case where I think the empirical evidence is actually pretty clear. So we haven't done what John's recommending, which is kind of, you know, total equalization through removal of the tax exclusion. But there have been various times when, say for self-employed individuals, the deductibility of insurance has changed and so forth. And there have been a lot of empirical studies of that by economists who point out that this is what happens. You know, if you increase the tax rates, you get less of health insurance, and that does translate into other forms of compensation. And this plays out in the CBO estimates that have been associated with all of these proposals. It is, you know, there are some revenues that come in from in the Cadillac tax or in these tax exclusion models from people, you know, having to pay taxes on these cap limits. But most of the revenue effects are actually from expectations based on empirical evidence that wages, taxable income, is going to be higher. That's the main revenue effect. It's much bigger than just the new limit associated with the exclusion. So I think this is a case where the evidence is pretty good, at least as, you know, according to most economists who have studied it, and CBO in interpreting the results.
So I had a question about the way you explained the tax credit in the Cassidy bill and how that would work. Someone who has type 1 diabetes is probably going to spend more than $8,000 a year on their health care, so they probably won't see an increase in tax credits versus a healthy person who probably isn't going to spend that much money. But that one person who got type 1 diabetes, it's not, I mean, that's a genetic issue. That wasn't, you know, their health choices, et cetera. How do we avoid discrimination based on that? I guess that the purpose of the healthcare law was to make sure that healthcare is accessible to everyone. We took away the pre-existing conditions clause and et cetera. How do we prevent that system from then affecting those individuals?
Well, even before there was an Obamacare, you know, the 150 million people who are getting insurance, that's half the population gets insurance from an employer. We already had a rule that said employers can't charge the diabetic higher premium. Now, you're right, the diabetic costs more, but the individual's paying the same premium everybody else is paying as far as deductions from paycheck. And so, so nothing changes there. Now, what Obamacare did is impose the same rule on the individual market, and we can argue about whether it was a good deal or not, but you know, even in most Republican plans, that isn't changing. Every Republican plan I've seen is still guaranteed issue. You can't charge the diabetic a higher premium than anyone else. That creates problems, which I think the designers of Obamacare didn't think through, but even in the Republican plans, that's still the deal.
Yeah, you make a distinction between the subsidy that people get for their health insurance and the premiums that they pay for health insurance. So, you know, understand the concern, especially in the individual market before the ACA, about people with type 1 diabetes or frankly a lot of other conditions getting underwritten and having higher premiums as a result. The ACA tried to solve that through the mandate, or, you know, as Chief Justice Robert called it, the tax. Under the Republican proposals, they would do away with the mandates, but instead there'd be a requirement for continuous enrollment in coverage. And if you did that, you'd still get guaranteed issue and community rating, with the idea of stabilizing the insurance markets that way. So that means people pay the same premium. If you pay the same premium, then the subsidy is going to be, you know, your $8,000 whatever subsidy is going to be worth the similar amount towards the cost of those premiums. We'll just add to that you know, it's not completely clear what the best way to stabilize markets is. You know, I'm not sure that the ACA mandates are doing it. You know, some concerns about how many people are really enrolling, and especially staying continuously enrolled, since they can come back in and out. Medicare has relied on something more like what's in the Republican proposals, which is, you know, you sign up for Part B and Part D when you're first eligible, or you can wait until later and do it. But if you wait till later, you're going to pay more.
And there's no mandate.
And there's not a mandate. And there's subsidies for everybody, regardless of their health status in Medicare, that encourages them, even if you're healthy, to stay in. It helps defray the insurance costs. I just add to that I do think this is a real issue, is that the difference in predictable risk. And while I was at CMS, we did a lot, not only to try to implement the approach that I just described successfully, but also to add to so-called risk adjustment approaches, which is upfront, based on, you know, sort of the predictable things that influence cost, give the plans in Medicare more money if they attract and keep people who have the high healthcare needs. And I think that's done a lot to help stabilize the markets as well, while also, you know, still encouraging people to choose. And, you know, my hope is that with all this interest in payment reform that's going on, that's going to extend not just to, you know, helping providers find new ways if they can deliver care more effectively at a lower cost to share in the savings, but there are ways to transfer that money back to the patients as well. The people who really ought to gain in a system that doesn't just put a whole lot of money into third-party insurance regardless of cost are the people with chronic illnesses, because there are so many opportunities to deliver that care more effectively, to make it more prevention-oriented. And you know, I think if we just gave those people with chronic illnesses more of a chance to share in those savings, to see a lot more powerful movement in a direction that actually gives them the healthcare system they want, not this fragmented, very costly, hard to non-transparent approach to getting care for chronic illness that we have so often today.
Because the wage issue, and you hear a lot about wage stagnation over the last 20, 30 years, and how much of the tax treatment for employer healthcare plans has contributed to employers not spending less on employees, but spending it differently as not wages.
Did you all hear that? He's asking about wage stagnation, and is the ability of employers to buy health care with pre-tax dollars contributing to that. Certainly, the growth in the cost of health care has contributed to that. And if you think that this tax incentive encourages employers to overspend on health care, then yes, the way we subsidize health insurance is contributing to wage stagnation, right?
Okay.
Yes, ma'am.
Yeah, you mentioned sort of in your new plan it would create more opportunities to incentivize savings, so employers could narrow networks or otherwise incentivize overall savings in healthcare. Traditionally, a lot of the ways employers have done that, though, is kind of shift costs over to patients with higher deductibles, more cost sharing. Have you guys done any modeling about what specific savings we would see from employers under this scenario and the ultimate total cost that could be transferred to patients in those scenarios?
Well, we'll let Mark speak to that in just a minute. Without a study, I can look at raw numbers, and I can say that if the decision makers are in a 40% bracket, right now, if they save $1, they only get to keep 60 cents. And if we move to a better system, they save $1, they get to keep $1. So numerically, I can see, well, there's a difference in incentives. Now, how much they're going to react to that, I can't tell you. Do we know?
No, the evidence is that they react fairly strongly, that there are not one for one, but significant impacts on the plans that people choose and on the cost of their health care. Like I was mentioning before, I think if you look closely at some of these studies and some of the results that make some policy analysts nervous, is that when people do cut back on their health care spending, at least in some of these historical studies, it's been a mixture of cutting back on stuff that's probably low value, like the extra MRI when you have a headache, and stuff that may be higher value, like preventive care. So there have been a number of steps that health plans and that policymakers have tried to implement to encourage better differentiation between the two. I personally think one of the best opportunities for encouraging more efficient use of care is really pushing on making better information on quality and cost of different treatments and providers more widely available. And that's something that, again, there's been some bipartisan interest in Congress in doing that. And if you really wanted to address this problem of high potential increases in out-of-pocket costs for people in really expensive plans, I think the way to do it would be some combination of more transparency, more ability for people who have high costs to share in the savings when they choose less costly care, and as a result of that, we can be more confident that when we reduce healthcare spending, we're really reducing the stuff that's not very valuable. We're really shifting to ways of delivering care that are more efficient.
Well, I want to thank you both for coming. It's a pleasure listening to you, and thank you all for coming.
Thank you guys for taking time.